Recording in progress.
A very good evening to one and all. I welcome you all to this edition of this month in endoscopy. Today we have two esteemed panelists along with us. We have Professor S.K. Sinha sir from the PGI Institute in Chandigarh, and we have Professor Ganesh Pai, who's from KMC Manipal. They'll be discussing the various papers presented today by Dr. Chalapati Rao, who's going to be presenting 4 interesting papers that he shortlisted. So without further ado, I ask Chalapati to start sharing his slides and to discuss the papers as we go along.
Good evening, everybody. So my slides are visible?
Yes.
Right. So good evening, everybody. Apologies for the confusion in time, and let us start. And I thank the panelists. So this is the 16th edition of this month in endoscopy, and we are going to discuss about 4 important articles that are actually published in this month in various journals related to endoscopy. So one is endoscopic suturing in various GI diseases, role of artificial intelligence in colonic polyps, multicenter study with regards to motorized spiral enteroscopy. And the 4th and last article is meta-analysis on the role of early versus delayed interventions in pancreatic fluid collections. So the first study is titled as Endoscopic Suturing for GI Applications. Initial results from prospective multicenter European study. We know that this Apollo overstitch endosuturing device is available through the double channel scope, and now it is compatible. A newer device is also compatible with the single channel scope. It is called overstitch SX. So these devices are usually used in endobariatric leaks, fistulae, mucosal defects, and ulcers, etc. Now, this study is intended to prospectively collect the technical performance and clinical data regarding to both the overstitch systems used in different GI applications. So the primary outcome is technical feasibility and technical success and clinical success. Technical feasibility is defined as introduction of scope to the region of interest. Technical success is successful placement of the sutures, and clinical success is resolution of the clinical symptom and clinical condition. Secondary outcomes are identifying those variables which influence the outcomes. So the study was done at 9 European centers between 2018 to 2021. And the defects, 4 types of defects are closed. 4 types of diseases were tackled with this device. Closure of the mucosal defects like ulcers, post-EMR ESG defects, enterotomy defects, and post-OM and STER defects were also closed using this system. Closure of full thickness defects like fistula, perforation, post-operative or spontaneous leaks, and anastomotic dehiscence were also closed. Fully covered metal stents were fixed to prevent migration, and other diseases like GERD, cardioplasty, and bariatric procedures, revision of bariatric procedures were also included into this study. So total of 137 patients were studied, out of which females were 58, with a mean age of 59.8 years. In all patients, the scope with the assembly was introduced into the region of interest, and technical success was possible in 99.3% of patients. Follow-up data was available up to 90 days in 101 patients, and clinical success was noted in 89% of patients. So, of note, the newer device that is which is compatible with the single channel scope, that is overstitch SX, was done in 23 patients, that is 16.7%. Technical feasibility and technical success was noted in 100%. Clinical success was noted in 88.2%. So with regards to the type of pathology and defect, 32 patients closure of mucosal defects were done with a technical and clinical success of 100%. 23 fistulas were closed with a technical success of 95.7%. With a lower clinical success, that is around 64.7%. 22 perforations were closed with a technical success of 100% and 94.7% clinical success. Less number of post-operative leaks were included in this study with a technical success 100% and a reasonably good success 83%. 38 stents were fixed and 85% clinical success achieved. And 15 other diseases were also tackled with 100% clinical and technical success. So amounting to that, the overall technical success is 93% and the clinical success of 89.1%. So on a different correlation matrix analysis, especially in the difficult to treat group, that is the fistula group, the authors have reported that if they applied continuous sutures and especially in the stomach, they achieved more success. But in rectum and if the fistula is more than 1 centimeter, they achieve less success. So coming to discussion, endoscopic suturing is safe and it is technically feasible to treat complex conditions at complex locations. That is more important. Though it is done at expert centers, but we should all note that all these complex cases are usually referred to expert centers. And in all cases, it is technically feasible and it can be done even at complex locations like upper esophagus or duodenal locations. So the main limitation is actually it is a short follow-up period and it is limited by small sample size, especially for post-operative leads. So I'm done with the first article, sir.
Sinha, sir. So you're muted.
So when you refer to table 1, I could not understand that part. There is numbers vary in technical success and clinical success. So what does that mean?
Yeah, so over a period of follow-up period
Like
around 90...
you see and in the clinical success. So the rest is lost to follow-up.
Yes.
This is lost to follow-up.
Yes,
that
sir.
is too high.
Yes, sir.
That is too high.
Right. So around 26 patients, they did not follow up, like up to 90 days. Like this clinical follow-up is available only in 101 patients. Hello? Hello? Hello?
Yes.
Am I audible, sir?
Yes.
Yeah. So if you see in this slide, around 101 patients, the follow-up data is available out of 137 patients. And so the clinic, so 26 patients have lost to follow-up.
36.
That is looks little high number, particularly in the instant fixation group. 38, we have only 17 on follow-up. So very large number are lost.
Yes.
So that will affect interpretation seriously.
Right. Yes, sir. Actually, this fixation is supposed to, give a better result, but unexpected. Hello. Hello.
You're audible. You're audible.
Yeah. Okay. Right. So, so usually these stand 6 devices, especially the suture devices, is expected to give a better result in stand fixation. But almost in 15%, still some migration has happened. Hello?
Yeah, personally, to me, this is a very early descriptive study, by which I mean it just gives us a long list of procedures the authors have done. These are very preliminary data, and it gives us an idea about what is to come. For example, there are fistulae where the clinical success is much lower. Now we need other studies specifically on fistulae or specifically on stents, specifically on other situations like post-operative dehiscence and so on. So these are very early data. So far, so good. They have shown that it's possible to do it in a large majority of patients, in expert centers, of course, with expertise, with experience. But then these are very early data. So it should be looked at only from that point of view. Yes, there are fallout, there are missing data, the follow-up is short, all, but that's what one expects in a very, very early preliminary study like this. To me, that's what. And the second point is the low numbers in fistulae are not very surprising, because fistulae, there are two aspects. One, a fistula might be very chronic. I don't know if we have any data on that. What is the age of the fistula? And secondly, there might be an underlying disease, such as Crohn's disease, for example, which might prevent the fistula from healing. So expectedly, in a condition like fistulae, the results were much lower. So that is what this paper is all about, as far as I'm concerned. Yes.
I will also like to add one point on that. Like in chronic fistulae, whenever we use, I don't have any experience with this device, but whenever we use Ovesco, like for tubercular fistula, chronic fistula, so then most of the time we make it raw using the APC, and then we apply the Ovesco, because otherwise our experience was not so good with the chronic fistula. So here I went through the whole article. So the procedural detail they have provided very little, and the second interesting point is zero adverse reaction, minor or major. Major I accept there might have been zero, but even minor is zero. So whenever zero adverse reaction, then we are always become little suspicious about that part.
True. Very true. Yeah. So shall we proceed for next article, sir?
I think so.
Are we allowing questions from the audience, or are there any questions from the audience on this paper?
So the backend team will transmit if there are any questions, sir. Sridhar?
As of now, none have been put up.
Yeah, good.
Okay. So the second is on colonoscopy. This article is published in CGH this month. It is about titled as Artificial Intelligence Allows Leaving in Situ Colorectal Polyps. So we know that 80% of polyps are diminutive while we are doing a routine screening colonoscopy, and we subject majority of them to polypectomy. And it gives a huge burden to the GI pathology department, and it also has heavy impact on the environment. So there is diagnose and leave in situ strategy is applied for rectosigmoid hyperplastic polyps, which are diminutive, and any other polyp, any other diminutive polyp in the proximal colon or adenomas, the resect and discard strategy is followed, and this saves a lot of dollars in the US and in the Far East. But we also should note that it requires sufficient amount of training in assessing these polyps using chroma endoscopy and high definition magnification endoscopy, and majority and some of the endoscopies are reported suboptimally, and there is a reluctance in the community gastroenterologists to practice this. So there should be a need for strict policy and more training for these gastroenterologists, and also there is a need for advanced imaging to achieve the benchmarks. So artificial intelligence has come up in a big way. It is also called as computer-aided diagnostic system. It gives the potential for in vivo histological prediction independent of the advanced imaging, and it also simplifies the process. So the aim of the current study is to study the optical diagnosis of polyps based on the output of the new CADX system applied to the white light, non-magnified standard endoscopy or colonoscopy system. That is more important. So they have the authors have used this GI Genius from Medtronic, which can be fitted even into a standard endoscopy and colonoscopy, and it can be used. So it's a prospective single-arm study from Italy. Any patient more than 40 years who is undergoing screening colonoscopy or a surveillance colonoscopy, or patient undergoing a colonoscopy based on signs and symptoms, or a positive fecal immunochemical testing were included in this study. Any patient who is having colorectal cancer, IBD, or underwent a previous colectomy, or those who are undergoing emergency colonoscopy, those who are on antithrombotic therapy, and those who couldn't provide consent, they were excluded. So two things were studied in this module, that is two module system. One is detection of the polyp and another is characterization of the polyp, which is labeled as CAD-E and CAD-X. So two systems, either Fusionon, that is Eluctio, or Olympus Avis X, there are three systems were used. All the polyps in rectosigmoid region were identified and resected either by using cold forceps or hot cold snare, and polyps were studied. So whenever a polyp is noted, it is washed thoroughly and it is focused and it is positioned preferably at 6 o'clock position. And then the GI Genius, that is the artificial intelligence system, get activated and the CAD-X report is recorded. But here the endoscopists did not use any zoom or virtual chroma endoscopy. And this is the first optical diagnosis, and this report is recorded. And then after this, the NBI or the BLI, that is the virtual chroma endoscopy system, is switched on, and the endoscopist has given a second optical diagnosis with a level of confidence which is assessed, and the morphology and location of the polyp are noted. So the primary endpoint is the negative predictive value for adenomatous histology of CAD-X optical diagnosis of diminutive polyps in the rectosigmoid region, and the secondary endpoint is the agreement in assignment of post-polypectomy surveillance guidelines, both European and US multitask force guidelines. And the performance measures for CAD-X were recorded, and the performance measures for virtual chroma endoscopy were also recorded in accordance with the level of confidence. So total of 162 patients were assessed, and no polyps were noted in 32 patients, and at least one polyp was noted in 130 patients. 50 polyps were not diminutive, meaning thereby they are more than 6 mm, and they were not included into the study. 494 polyps were diminutive, out of which 295 were located in the rectosigmoid region, and 181 polyps were located in the proximal colon. So after resection, 256 polyps out of this 295 were reported as non-adenomas, and 39 out of this 295 were reported as adenomas. And if you go back to the first optical diagnosis, that is CAD-X, 235 out of these 256 non-adenomas were accurately predicted by CAD-X. And on the other arm, 32 adenomas were accurately detected on CAD-X based after getting histology. So in the leave in situ strategy, the negative predictive value goes up to 97.6%. And in the resect and discard policy, it goes up 96 and 97% as in accordance with the post-polypectomy interval assignment agreement in both European and the US multi-society task force guidelines. And of note, we have to note that 17 non-adenomas were detected as adenomas on CAD-X, and 7 adenomas were detected as non-adenomas in CAD-X. So, so if you compare between the endoscopist, that is endoscopist using virtual chroma endoscopy versus CAD-X white light endoscopy, it is available. The CAD-X is available in 98.6% polyps. The virtual chroma endoscopy was available in 94.6% of polyps. The negative predictive value is similar, 97.6%. The sensitivity is 82% versus 81%. The specificity is 93% versus 98%. The positive predictive value has dropped in CAD-X white light group compared to the virtual chroma endoscopy group. It is 83.9% here. The accuracy is 91.8% in the CAD-X group and 96.1% in the virtual chroma endoscopy group. So meaning thereby, even without the availability of virtual chroma endoscopy, if we add this artificial intelligence system to the white light endoscopy, there is a similar diagnostic performance, especially in the negative predictive value and sensitivity of these polyps. So what is the agreement of this optical diagnosis based with histology based on the post-polypectomy surveillance interval? So how does it fare? So it is in agreement with these guidelines. If as per CAD-X white light, it is 95.6% with the ESG guidelines and 95.9% with the US guidelines. If we use virtual chroma endoscopy, it is 96.5% agreement with the ESG guidelines and 95.9% in agreement with the US guidelines. So coming to the discussion, CADEX has achieved more than 95% negative predictive value for adenomatous histology polyps. And this can potentially result in reduction of 44% reduction of all polypectomies and related costs in the leave in situ strategy. Coming to the resect and discard strategy, it would reduce the need for pathology up to 83% with more than 95% agreement with existing guidelines for the post-polypectomy surveillance. It's a good cost-saving strategy, and it obviates the need for high-definition magnification scopes and advanced imaging as per the author's statement, and it reduces the need for polypectomy as well as the pathology costs. And CADEX, more importantly, CADEX diagnosis using just with the white light endoscopy is in agreement with the endoscopist diagnosis when he or she has used the virtual chroma endoscopy. But the limitation is there is no randomization or there is no independent comparison between the groups, and sessile serrated lesions are underrepresented, and the polyp size and polyp size estimation may not be uniform in all these patients.
Sinha, sir?
Two comments. One is interpretation of data. So if you see, like you put 5,000 cases of non-adenomatous and 50 cases of adenomatous, and the system misses 25 out of that. So 50% of adenomas are missed, and still you will get accuracy rate of 90%, 95% plus. So if you see the first slide initially, we have histology adenoma 39, a small group mein, and it goes wrong in 7. Okay, so almost 20% it goes wrong. And in larger polyp group, 135 adenoma, and it goes wrong in 22. So almost 20% it is going wrong. So I will interpret that because every missed adenoma is a litigation. So that is point number one. Second, I have some first-hand experience of involved in the development of such program. So I was working with Endovision Hong Kong, which is a startup from Indian IIT guys, and then we were developing the program. And this program, some of you have seen Dr. Goenka showed that program, part of that program, very small part of that program in one of the endoscopy meeting. So, so what happens that you need a very clean area for detailed evaluation. So little bit compromise in video quality or disturbance, or if you have little bit of residue or surface coating, the performance of the AI software decreases, and you cannot be very fast on that. So that takes a little bit of time. So that adds. But given that, I actually disagree with 95% accuracy. For adenoma, the accuracy rate is possibly around 80%.
Yeah, interesting analysis from Dr. Sinha there. But then again, you see, this paper is very cleverly worded, and probably rightly so, in the sense that they are looking for a negative predictive value. And the amount of polypectomies or histologies that can be decreased. So in that sense, the paper does add value to what we already know. This is my way of looking at it. Agreed that the miss rate of adenomas was quite high because of the low denominators in those groups. Yes, this is the way I look at it.
But the issue is that every adenoma is missed is a soil for litigation.
Yeah. Yes, that's a point to be kept in mind. The implications might be, these are diminutive adenomas. The implication might be in the long term, in the sense that a missed adenoma is missed. But if it grows into a cancer over time, so the exact implications of these need to be looked at in further studies. That's the way I look.
So actually, as you said, this is intelligently worded. The title itself says artificial intelligence allows leaving in situ colorectal polyps. So yeah,
Hmm.
yeah, that's very interesting.
Hmm.
Yeah. But as you said,
So
if we are
data
missing like
is
20, it's the way how you project and play the play the data. Yeah. As
how
we
do you
were discussing.
show the data?
Yeah, yeah. As we were discussing yesterday with Dr. Sridhar about some other paper and study, like if we change the endpoints and study outcomes, the value of the paper and the review completely changes. Your yeah, that's a very interesting analysis, sir. So we'll move on to the next paper, sir. So the third paper is on spiral enteroscopy. So this is actually titled as Performance and Safety of Motorized Spiral Enteroscopy, including in patients with surgically altered and altered GI anatomy, a multicenter prospective study. So this is published in this month of Endoscopy journal, November 2022. So we know that small bowel endoscopy has been revolutionized by the advent of video capsule endoscopy, double balloon enteroscopy, and single balloon enteroscopy. It allows us both the visualization as well as performing of various therapeutic procedures. So this motorized spiral enteroscopy is the new kid in the block, introduced somewhere in 2015. And actually, it has a spiral overtube which can be auto-propelled using a motorized system, using with it's controlled by the foot pedal with both backward and forward movements. And this spiral overtube movements will be converted into a linear energy, which propels the scope either forward or backward, allowing a deeper enteroscopic examination. So 5 Dutch centers are involved in this study, which has looked upon at the performance and utility of motorized spiral enteroscopy in various small bowel disorders. So the inclusion criteria are like any patient with more than 18 years are included, patient with suspected small bowel disease on video capsule endoscopy or CT or MRI were included. Any patient who is already having the diagnosis and need a therapeutic enteroscopy are included. Patients providing informed consent are included. But those patients with severe GI inflammation like strictures or ulcers were excluded. Patients with large esophageal varices, patients who are in intestinal obstruction, eosinophilic esophagitis are excluded. Patients with coagulopathy and thrombocytopenia were excluded. Pregnant patients, American Society of Anesthesiology category more than 3 were excluded. Those who are unable to tolerate GA or sedation were excluded. So the various parameters were actually studied. Procedure time was defined as complete enteroscopy procedure in and out of insertion and withdrawal of the scope was recorded. Technical success is when you actually cross the ligament of Treitz in antegrade procedure or cross the IC valve in the retrograde procedure is recorded. Total procedure success, total enteroscopy rate was also studied. Premature discontinuation was defined when you have to discontinue the procedure because of before reaching the point of interest was recorded. Depth of maximal insertion, either distal to the ligament of Treitz or proximal to the IC valve was recorded, though it is very arbitrary in spiral enteroscopy. Diagnostic yield is the yield of diagnosing a lesion which was already diagnosed on video capsule endoscopy or radiologic imaging was recorded. Therapeutic yield is the number of therapeutic procedures that are done for any diagnosed lesion was recorded. Adverse events like minor or major are also recorded. So the procedures were done under deep sedation using high flow nasal cannula or general anesthesia. The primary endpoints are diagnostic and therapeutic yield and safety of motorized spiral enteroscopy. Secondary endpoints are technical success, depth of maximal insertion, procedure time, total enteroscopy rate, learning curve effect were also recorded. The study was carried out between March of 2020 and September of 2021. So total of 170 patients were included. Males were 102, median age was 64 years. The patients were excluded. 7 patients were excluded because their ASA more than 3 category and unfit for the procedure, and 1 patient had large esophageal varices. So majority of patients up to 70% are ASA category 2. 23.4%, 23.4 kg per meter square is the average BMI. More than 90% of patients, or 93% underwent these procedures under propofol sedation, which is in contrary to the previous studies where general anesthesia was deemed to be mandatory for this procedure. So in that way, this study carries a lot of significance. Suspected mid-gut bleed or iron deficiency anemia was the predominant indication in 2/3 of patients. Around 8% had overt GI bleed. 85% patients had a prior video capsule endoscopic study. And more importantly, 20% of patients had a surgically altered anatomy. Like previous studies, all these surgically altered anatomies were excluded in the previously published studies, but this study, at least 20% surgically altered anatomy cases were included, predominantly small bowel resections, colectomies, Whipple surgery, ruined by gastric bypass, and Billroth 2 surgery, Whipple surgery, etc. So coming to the diagnostic yield, around 64% is the diagnostic yield. Around 1/3 of patients were vascular lesions, predominantly AV malformations. Around 14% were inflammatory lesions like ulcers or strictures. Mass lesions like polyps or tumors were noted in around 11% of patients. Therapeutic yield was noted in 53.5%. APC was the common procedure done in 2/3 of these patients. 10% of patients, clips were placed. Around 8% of patients, stricture dilatation was done. Anastomotic dilatation was done in surgically altered anatomy patients in up to 4.3%. EMR of tumors was done in around 8.7% of patients. More importantly, total enteroscopy was achieved in more than 70% of patients, out of which in 42% of patients, bidirectional routes, that is both antegrade and retrograde routes were needed. And majority, these two procedures, antegrade and retrograde procedures, were done in the same index session. And total enteroscopy rate, even in surgically altered anatomy patients, was achieved in up to 24.4% of patients. And to achieve this total enteroscopy up to 70 minutes, the authors have took. So adverse events, up to 15.9% patients had adverse events. Fortunately, none had serious adverse events. But predominant adverse events are superficial mucosal abrasions, deep mucosal tears, and submucosal hematoma. So during this procedure, adverse events were recorded in 13 patients. And after the procedure, patients reported sore throat in 8 patients, 4 patients reported pain, and 1 patient reported GI bleeding. So coming to the route of enteroscopy, 85 patients had antegrade, 39 patients had retrograde enteroscopy, and 46 patients had bidirectional enteroscopy. Technical success was noted in 96.5 in the antegrade route, 100% in the retrograde route, and 93.5% in the bidirectional group. So the procedure time appears to be shorter in motorized spiral enteroscopy, 45 minutes in antegrade, 40 minutes in retrograde, and 70 minutes in bidirectional. Depth of maximal insertion is also deeper, 350 centimeter in antegrade, 150 centimeter in retrograde, and 400 centimeter in the bidirectional group. So this depth of maximal insertion is arbitrary as of now, but still it is recorded as per the endoscopist's discretion. The insertion time is 25 minutes in antegrade route, and in retrograde route it is 30 minutes. Withdrawal time is 15 minutes and 10 minutes in respective groups. More importantly, the cecal intubation time is around 7 minutes in the retrograde group, and there is no phase where the procedure had to be terminated prematurely. So coming to the discussion, motorized spiral enteroscopy can achieve a high diagnostic and therapeutic yield, and more importantly, pan enteroscopy in up to 70% of patients. Surgically altered anatomy, 20% of patients are included in this study. That carries significance to this paper. And total enteroscopy rates are achieved in 24% of these surgically altered anatomy patients. Though I did not discuss in the result section, this appears to be easy to learn and perform. And minor adverse events occur in up to 15%, especially abrasions and tears of the mucosa. And this is the first study to demonstrate that MSc can be performed under deep sedation also. And also there is no need for mandatory upper esophageal sphincter dilatation as was reported in previous studies. Fortunately, no hemodynamic changes or respiratory compromise happened, even though this study was done under propofol sedation. Compared to other enteroscopy devices, motorized spiral enteroscopy appears to have shorter procedure time, but with the same diagnostic and therapeutic yield as other device-assisted enteroscopies. But compared to small bowel single balloon enteroscopy, the depth of maximal insertion appears to be deeper, and it may be equal to double billing, or it may be higher than double billing enteroscopy. Total enteroscopy rates definitely are higher than the single billing enteroscopy, and probably it is higher than the total enteroscopy rates achieved by the double billing enteroscopy also. But the current limitation of this study is that there is no head-to-head comparison with single billing and double billing enteroscopy. It's just an observation study. And currently, all these publications and this technology is available and published at expert centers only.
Again, a descriptive study, more of a descriptive study than a comparative study. So we have to take it at that level. But a couple of the paper might be hiding some data. That's what I felt. For example, 70% or so had undergone a video capsule endoscopy. I need to look at the slide, but 70% or so had undergone.
Around 85%.
Pardon?
Around 85%.
Around 85%. Now, if you give me a very high diagnostic figure on this after your video capsule, then I would like to know what was the additional diagnostic yield, because that figure would make more sense to me. The second thing is there was a small proportion with altered, and there was a proportion of patients with altered anatomy. But if you actually look at it, many of them are resections, colonic resections or strictureplasties. So it is not the kind of altered anatomy where you might expect a difficulty in intubation, like anastomosis, side to side, end to end, end to side kind of anastomosis. Agreed, when you have a resection, you might have adhesions in place, known, unknown, symptomatic, otherwise. They may, in known or unknown ways, influence your enteroscopy in some way. But some of these were actually colonic resections. So even in the title, they say with altered anatomy. To me, that's not such a big point. So these are the couple of things that I came across, which looked a little suspect in this whole paper. Otherwise, it's a descriptive study, and we have to take it at that. Yeah.
To me, the most important part appeared to be procedure in surgically altered anatomy. The completion rate, they said 24%. But what about the rest of the patients? What happened to other patients with surgically altered anatomy?
So that 24% is only the total enteroscopy. It means like from the antegrade route reaching the cecum, or in the bidirectional route reaching the point of clip or the tattoo.
Other patients, it was not attempted, not possible, or had to discontinue for some reason. That is, I found that information is not clearly available.
Yes, that is not clearly available. And the total enteroscopy is attempted only in those patients where there is no luminal stricture or mass, and probably only some GI bleeding lesion will be there, or the mucosa may be entirely normal.
That's right. Yes.
Yeah. So shall I proceed to the last study, sir?
Yeah. Yes.
So the final study that we selected for discussion is a meta-analysis. This is published in DEN Open Endoscopy. So it is titled as Early versus Delayed Interventions for Necrotizing Pancreatitis. It is published from the wonderful study group from Japan. So we know that infected pancreatic necrosis carries a high mortality. And previously, early surgery was done, but there is a paradigm shift, and people resorted to a delayed strategy. And the invasive surgery has become obsolete, and now people go more for minimally invasive surgery. And any aggressive surgical approach is preceded by a step-up approach, after the Panther trial. And now we use more of percutaneous drains and endoscopic drains and minimally invasive surgery for these group of patients. But more importantly, we should know that infection can occur. We all know that infection can occur in the course in any part of the course of pancreatitis, even in early course. And sometimes we falter in actually calculating the onset of pancreatitis. Sometimes patient can be referred late after some 3 days or 5 days, and it may be doubtful also. And we intervene in these patients early, especially if they don't respond to antibiotics, and we need some kind of intervention, either percutaneous drainage or endoscopic drainage or a surgical drainage. So the meta-analysis in this study was done to evaluate the treatment outcomes of early and delayed interventions in acute necrotizing pancreatitis. So it is done by the wonderful study group, that is Vaughan and Peripancreatic Fluid Collection Study Group from Japan. They searched around 6,667 articles between 1990 to 2022. And after excluding the duplicates and excluding the other abstracts and those who did not fit into the category, 11 studies were included in the analysis. And in accordance with the PRISMA guidelines, this meta-analysis was conducted. So those studies where the timing of intervention was mentioned, either early, that is less than 4 weeks of duration of onset of pancreatitis, or delayed, that is more than 4 weeks of pancreatitis, based on revised Atlanta classification, were included in this study group. A threshold of 4 plus minus 1 week was used, and all those studies with at least more than 10 patients were included in this study. And any patient who had postoperative coming into the postoperative category or traumatic pancreatitis were excluded, and those patients where the category of the cyst, whether it is a pseudocyst or a walled-off necrosis, the nature of the cyst was unclear, all these patients were excluded, and all these 11 studies were retrospective studies. So the primary endpoint was adverse events. They are defined as per various guidelines. Some use ASG lexicon. Some defined it as intra-abdominal bleeding or intraperitoneous fistula, slippage or blockade of the catheter, and adverse events likely related to endoscopic intervention, any patient with having stent migration or perforation, and any abdominal vein thrombosis. So every study had a different categorization or definition of adverse events. Secondary endpoints were defined as technical success, which are reported in only two of these studies, like successful deployment of the metal stent in endoscopic studies. That is mentioned as technical success. Clinical success is defined as reduction in the symptoms, reduction in the volume of the cavity, resolution of the cavity, etc. in this clinical success group by various authors. And other secondary endpoints were recorded that are need for necrosectomy and mortality. So as expected, the early intervention group are more sicker, like the organ failure is higher in the early group in at least 3 or 4 studies, and 3 studies have studied exclusively the percutaneous catheter drainage, and 4 studies have evaluated the endoscopic drainage group, and the rest all studies were combination of percutaneous, surgical, and endoscopic studies. So if you come to the results section, compared to the early versus delayed intervention group, the adverse events did not differ much, with an odds ratio of 1.41, but the mortality was higher in the early intervention group with an odds ratio of 1.7 odds ratio. Moreover, the clinical success, that is the resolution of the collection, is or radiological resolution or resolution of symptoms. They were reported in 5 studies, but that is lower in the early intervention group with a pooled odds ratio of 0.39. More importantly, the requirement of necrosectomy is higher with a pooled odds ratio of 2.14, and the requirement of surgery did not differ between the groups, early and delayed intervention. But if you actually closely look into this endoscopic group, early intervention was more required in early requirement of surgery was more in the early intervention group. Both the early and delayed intervention had similar technical success, and it has similar hospital and ICU stay. the early intervention did not reduce the hospital stay. And when you are using lamps for endoscopic drainage, it did not correlate with more adverse events, and it did not it did not lead to a better clinical success. So coming to the discussion part, the delayed interventions followed by step-up approach is reasonable in terms of safety and effectiveness. And this current study actually did not study much of a benefit with early intervention across various modalities, that is endoscopic, percutaneous, and surgical drainage route. And we usually delay the interventions because we can see certain resolution of these collections just with medical management, and this can avoid unnecessary interventions in the early course of pancreatitis. And when you're delaying the interventions, this allows complete encapsulation of the cavity. And early drainage actually carried higher mortality in this study. This can be because of ongoing pancreatitis process. And by intervening in these patients, actually the inflammatory process might be increased, and there can be spillage of contents during the intervention, causing more harm to the patient. And it is always important to select the symptomatic collections which are due to infection rather than ongoing pancreatitis. And this group might be benefiting with this early drainage. And this actually draws us to the need for better biomarkers and predictors for detection of infected pancreatic necrosis. So there are a lot of limitations for this study, though it is a meta-analysis, but there is a lot of bias because all the studies are retrospective, and we actually tend to intervene in these patients early if the patients get worsened without any protocol. So this is the bias, and this is the drawback of retrospective studies. And there are limited number of cases, and the onset of pancreatitis is not always clear, as I have discussed in the introduction part. And also there is no clear data on the timing to encapsulation, which might be more important than the timing of intervention, because in certain cases we can see that encapsulation has happened even after third week also. And so currently there is no support to routine utilization of early interventions in acute necrotizing pancreatitis. To conclude, early intervention is associated with higher mortality rates, and it did not reduce the adverse events or improve the clinical success. And more prospective studies and RCTs are needed in this subject.
So, couple of points. One is this comparison is a little unfair, because it always happens that when the patient is deteriorating, we tend to go for percutaneous intervention, and that is how the patient gets intervention within 4 weeks. This study has included 2 studies from PGI. One is by Dr. Bipad, in which I happen to be co-guide. This is earlier, I think, around 17, 18, this study was conducted. And second study by Dr. Surinder Rana, that is 21 study that was subsequently. So in earlier studies, this is one part of the study which has been published, that what happens to PCD, outcome of PCD early and late. The second part is which is still not published, but that was presented in Endoscopy Society meeting and got a prize in that. That if in early or late combined data, if PCD is combined with transpapillary drainage, that improves the outcome significantly, and that reduces the mortality and the surgical intervention. So that is point number one. But my contention is same, the first which I said earlier, that earlier basically early intervention selects out those patients get selected out which are very severe. So severity is not same in the 2 subset of patients.
Yeah, basically I had the same comments to make. Clearly, it appears that the early intervention group had very sick patients, and that might be the reason why the mortality is higher in them. Now, so we are back to square one. Early intervention doesn't seem to help, and the authors do give data. 40 to 60% of those with necrotizing pancreatitis with collections will, including those with infected necrosis, can probably be managed conservatively. And then when a patient continues to be symptomatic early in the course of the disease, it can be extremely difficult to say whether it is the collection which is causing the infection which is causing, whether it's the pancreatitis which is causing the patient's symptoms, based on which our decision to intervene on the collection has to be taken. So we're back to square one. The only saving grace of the study is that if tomorrow I have a patient early in the course of the disease, I'm fairly certain that drainage is likely to help him. At least so much of backup is there in the literature to support me if I go in. That's the way. That's the only small saving grace from the study. Otherwise, very heterogeneous retrospective studies combined together. But then, if that is the status of the literature, that's the status of the literature. What else can we say?
And it might be very difficult to randomize patients also, because it's very difficult to match in each and every set pertaining to the severity, pertaining to the cells or the organ failure and the size and amount of necrosis and collection.
It will be almost impossible to get ethical clearance. If the patient is deteriorating in second week or third week, you cannot delay everything for fifth week or sixth week.
True. So any questions from the audience?
No.
Okay.
No question.
So I thank all the panelists for their active participation. We really respect the time that you have taken, sir. So we have an exciting session again coming on 20th of December. That is the third Tuesday again at 7:30 to 8:30. So, and Dr. Sridhar will be speaking upon, and two more expert senior faculty will be joining us. So thank you, sir. Thank you, Ganesh, sir, and thank you, Sina, sir, for spending your valuable time. Thank you, and giving your expert comments.
Thank you very much.
Thank
Good
you.
night.
Thank you.
Thank you.
Thank you. Good night. Good night.
Recording stopped.